Hello, my name is Andrew Dwyer. I'm an assistant professor at Boston College, and I'm also an investigator in the MGH Harvard Center for Reproductive Medicine. This presentation is the identical presentation that I gave at the patient meeting, the virtual patient meeting on July 17th, 2021. Importantly, this presentation and the information herein is intended to provide information and as an educational resource for patients and families. It is not intended to provide medical advice, and any healthcare decisions should be made in consultation with your provider. So here's an outline of what I'll cover. I will skip through the ground rules because that's really relevant for the patient discussions. I will provide an overview of hypogonadotropic hypogonadism and Kallmann syndrome. And then I'll talk about the psychological aspects of HH and KS. And then we'll move on to the end of the presentation to discuss some work that's currently undergoing to respond to unmet patient needs and finish with some take-home points. So some key points to think about HH and KS is that this is a rare disorder. So it's estimated to occur in between 1 in 10,000 and 1 in 48,000 individuals. And there are strong sex differences, meaning that there is a sexual discordance. Approximately 4 males are diagnosed for each female case. And really the reason for this is not fully understood. The condition is characterized by a lack of pubertal development and infertility. However, it is important to recognize that this is one of the treatable forms of infertility. It is important to recognize that it is a difficult condition to diagnose, and that contributes to the diagnostic odyssey, or the very long time that many patients wait to get properly diagnosed with HH or KS. And there is a wide presentation of HH and KS. It is a spectrum, so not all patients have the same presentation, and there's wide variability between individual patients. And importantly, unlike many rare diseases, there are effective treatments available, both to induce secondary sexual characteristics, which we'll talk about, as well as to induce fertility, which is possible in about 80% of patients with HH and KS. So again, this is characterized by a lack of puberty. So this figure on the left shows you kind of the hallmark signs of going through pubertal development. So pubertal development are the biologic changes that culminate in the ability to reproduce. And so during puberty, there are a number of important things that happen physically. There's a growth spurt, there's an increase in lean muscle mass in males, there's a change in body composition with a broadening of the shoulders, there's development of the genitalia. And while in the general population, the onset of puberty is highly variable, but the sequence is consistent, and this is nicely shown in this figure here. So the first sign of pubertal onset is an increase in testicular size, then the development of pubic hair, and then a growth spurt followed by sperm in the urine. So if you actually take a urine sample of boys in puberty and centrifuge it or spin it very fast, at the very bottom you will see sperm in the urine, and that's evident that the sperm is developing before full reproductive and sexual capacity is reached. And then it's followed by the completion of puberty, marked by Tanner stage 5, and then a final maximum strength development. In females, we also see remarkable changes in terms of physical development. We see a growth spurt, we see the development of breasts, we see a change in body composition, so kind of a redistribution of fat mass. And there's also development of pubic hair and the onset of the menstrual period or the monthly periods. So again, there's a range of onset, but the sequence is always the same. So the first sign of puberty is breast development, followed by a growth spurt, and then the first menstrual period about 12 to 18 months after that breast development, and then the completion of puberty. And girls typically initiate puberty earlier than boys. So as I said, HH and KS is hard to diagnose. And so these figures show you some data from work that we did a few years ago looking at a group of women and a group of men. And this gray bar shows you the average timing of when healthy young women complete puberty, plus or minus 2 standard deviations. So that's kind of the range you would expect to see the vast majority of women to complete puberty. And you can see the age of diagnosis for women is very much later than that. So the mean age, or the average, is about 21, and the median or middle is about 18. And in males, it's quite similar. So here you can see that gray bar where most boys will complete puberty, and the vast majority of cases are diagnosed much later than that, all the way up into the mid-30s. And the average age is about 18, and similarly with the median. So many folks are not diagnosed until later in their adolescence, and that can be challenging because these individuals don't develop secondary sexual characteristics. They don't look like their peers, so they look really like a 12-year-old young adolescent, whereas their peers are progressing and advancing through their puberty and sexual development. So there's a spectrum of phenotypes or clinical characteristics that we think about associated with HH and KS. So in males, these men may not have a deepening of the voice. They may not have virilization or the development of facial hair. They won't have that increase in muscle mass, and they may have scant body hair and underdeveloped genitals and absent or very scant pubic hair. So really failing to progress through puberty. In females, it's quite similar. So absent or limited breast development, not having that redistribution of fat mass, so not having that characteristic hourglass figure that most women have, and then also an underdevelopment of the pubic hair, as well as amenorrhea, which just simply means a lack of menstrual periods. Now, there are a number of other things that can be associated with HH and KS. Now, these don't occur in everyone, but they occur at variable rates. They may include some sensory issues, such as lack of sense of smell. When HH occurs with no sense of smell, that's termed Kallmann syndrome. Some individuals have deafness, sensory neural hearing loss. They may have a midline defect, such as their lip and palate didn't fuse normally during development, or they may have missing teeth. A small proportion of individuals may have congenital heart defects, which there's something abnormal in the development of their heart. They may have weak bones, which is called osteopenia or osteoporosis, and they may have scoliosis, which is a curvature of the spine. A portion of patients with HH and KS may have what we call unilateral renal agenesis, and what that means is that instead of having 2 kidneys, they only have 1 kidney. Typically we see an underdevelopment of the genitalia, and some folks have what we call synkinesia, which is mirror movement. So if you wiggle your fingers on one hand, the fingers involuntarily move on the other hand. Now, this can be very subtle, and likely no one would find it or observe it unless they were doing a very detailed clinical exam. And in some folks, they have very short fingers or may have their fingers fused at birth. So when we think about treatment, once these folks are diagnosed, there's really 2 different goals. So one is to look like their peers, so kind of catching up in that pubertal development and developing what we call the secondary sexual characteristics. As we showed on the previous slide, these are things like virilization in males, developing body hair and beard growth, deepening of the voice, developing of the pubic hair, etc. And those can effectively be induced by sex steroids. And sex steroids for males is predominantly testosterone treatment, and in females, it's estradiol. And then later, after estradiol is initiated, they can add progesterone, and that initiates the monthly menstrual cycle. So in females, estradiol treatment will induce breast development and the characteristic body changes that we see with a redistribution of fat, as well as development of pubic hair. And when you add progesterone, you'll have the onset of menses. However, sex steroid treatment is very effective. While it's very effective for inducing secondary sexual characteristics, it won't induce fertility. So people will remain unable to conceive. So for fertility treatment, that requires a different type of treatment. That can be either gonadotropins. These are hormones that are secreted by the pituitary gland in the brain, and those are delivered via injection under the skin, so not a intramuscular injection, but just under the skin, or replacing the hormone that's lacking in HH and KS, GnRH, and that's delivered via a small microinfusion pump to deliver GnRH. And that microinfusion pump is a little bit like a diabetes pump. So patients with type 1 diabetes may have a pump for insulin. It's a similar concept, although the structure of the treatment is slightly different, and this is typically only done in very specialized centers from clinicians who have a great deal of experience in delivering this treatment. But overall, approximately 80% of patients can develop fertility with appropriate treatment. That's with either gonadotropin treatment or with pulsatile GnRH. Now, because HH and KS is different than other rare diseases, meaning that we have treatments to induce secondary sexual characteristics and fertility in most patients, there's been a long-held belief, and this is a quote from an article from 1964 from the Annals of Internal Medicine, and the quote is, "There's a tendency among physicians to assume that a corrigible pathological condition ought to be corrected and that the emotional well-being of the patient will improve concomitantly with his physical condition." So what this is saying in kind of simple terms is that if somebody's lacking these hormones, then we ought to replace them. And once you replace the hormones, their well-being should improve. Well, this has been kind of a long-standing dogma or belief in medicine, but there was very little data to really support this position. So what we did is we undertook a study where we surveyed a large group of patients with HH and KS, and we asked them simply, does your healthcare provider understand the medical aspects of your condition, HH and KS? And we were really pleased to see that 2/3 of patients, or 67%, said, yes, I feel like my provider really understands kind of the genetics, the pathophysiology, the treatments for my condition. And then we asked them, do you feel that your healthcare provider understands the emotional impact that this condition has had on your life? And this was a significantly lower percentage of patients who felt like their provider really understood how living with HH and KS has affected them, living with this rare condition, and that was only 38%. So we sought to explore this further and really understand this with the idea of if people have unmet needs around living with this rare disease, what are the things that they need to improve their quality of life, and how can we best work with patients to co-create solutions to help not only normalize their sex hormones and reach their fertility goals, which are medical objectives if they choose to pursue fertility, but also how can we best support them in coping with this condition and living with this rare disease? So that brings us to some of the psychological aspects of HH and KS. So we asked patients, what do you want? What would be helpful for you? Well, the first thing that came out loud and clear was finding expert care. And this is a quote from a patient. I am having a hard time finding a healthcare provider who knows what I have. The second major theme was this feeling of isolation and insecurity. So Kallmann's was very traumatic for me in my teens and 20s. Being able to connect with others would have been very helpful and reassuring. And lastly, patients had a strong desire for information and support. Another quote is, I wish I had more information and more support. Finding the group on Facebook was extremely helpful. So we sought to examine this issue of what is the impact of living with this rare disease and what are the things that help people cope better. So this is a kind of a busy figure, but basically what we looked at is we looked at their depression symptoms. We looked at what were the consequences that HH and KS had on their life, what was the emotional impact on their life, and how did they make sense of the condition, and we compared that to the age of diagnosis. And what we found is that there were 3 distinct groups. As you can see here, these shapes are very different. So there are really kind of clusters of groups, with some people having very high depression symptoms and other folks having fewer depression symptoms. And really what is interesting is that the earlier that people are diagnosed and initiated with treatment, the better they are able to manage and understand and cope with their condition, and their depressive symptoms are significantly lower. So it's a very important thing to try to move diagnosis earlier. So rather than that graph that I showed you where people are typically diagnosed at 18 or older, we really want to try to move that earlier to help improve the quality of life for patients. And there are really three areas that came out in our research thinking about how does living with HH and KS, how does that psychologically and psychosocially and emotionally affect people? And really there were three big categories. One was this overwhelming sense of isolation that many people had living with this rare disease, feeling like there was no one else who really liked them or who really understood. The second aspect was real concerns about their body image. So, having gone through puberty and looking very different than their peers, even after treating people with sex steroids to induce those secondary sexual characteristics, a lot of that concern around body image and insecurity around body image persisted even after treatment was established and long-term after 1 year. And not surprisingly, that contributed to challenges in creating intimate relationships. So really, these were kind of three interacting components that affect that. So when we think about isolation, that was strongly associated with symptoms of anxiety and depression. In terms of body image, people felt ashamed of their body and felt quite insecure about their body. And in terms of intimacy, people had challenges in terms of their psychosexual development and really overcoming shame and being able to form intimate relationships. So these are really key targets to help improve quality of life for patients with HH and KS. So one of the things that we did is we worked with together with the patient organization to really better understand the needs and kind of chart a roadmap to think about how we can address some of these things. So one aspect was how can we improve the psychosexual aspects of HH and KS? And psychosexual development is influenced by a number of factors. So first, there's the biological factors. Second, there's a social context in which people are growing up. And third are psychological factors. So let's just talk about each of these. In terms of the biological, your age is a contributor to psychosexual development. So if you think about an 8-year-old versus a 15-year-old, they may be very different. Also sex, males versus females, your hormones, your hormone levels, and also your genetic makeup. In terms of social factors, certainly your parents and your home environment, your peers play an important influence, as well as the images and messages we receive from the popular media, as well as the cultural norms. So across cultures, not every culture has the same attitudes and beliefs around psychosexual development, and those are very strong cultural influences. And in terms of psychological factors, forming one's identity, which is a key milestone in adolescence. So puberty is the biologic change culminating in your ability to reproduce, and adolescence is a more of a psychological and emotional and psychosocial change where you're leaving the roles and expectations of a child and taking on an adult role. So being able to solidify that identity during that time, it's a very key period for solidifying one's sense of their gender. Are they more masculine or are they more feminine? And those are not polar opposites, but really on a continuum. Their body image, how confident or insecure people may feel about their body, as well as their self-esteem, how confident they feel about themselves and their sense of identity. So this is just a summary. It's a very busy table, but I'll kind of give you the key points. And this is from a paper that we published last year, which reviewed that these are all the studies that have been published looking at psychosexual effects on patients with HH and KS. And these are patients before treatment, and you can see they had impaired health-related quality of life and impaired sexual function. And they also had significant depression symptoms. And interestingly, some studies followed these patients out looking at after treatment what happened when we initiated either testosterone replacement therapy in males or fertility-inducing treatment. And while we do see that some aspects of health-related quality of life improve, there are a number of factors that don't improve. So simply normalizing the hormone levels doesn't simply make everything go away. So that kind of these data refute that quote from the 1960s that I showed you earlier on the slide. And then we look at males on long-term treatment. And again, you can see significant depression and psychological distress, low rates of sexual activity, high rates of depressive symptoms, impaired health-related quality of life. And these findings are relatively consistent. And these were studies that were done in Finland, in Greece, in Lithuania, in Japan, in Turkey, as well as the United States and the UK. So really, regardless of culture, there seems to be a significant impact of psychosexual effects on males. In terms of females, there are only 2 studies that have really examined this. So this is the data are a little bit similar to the males in that there's some evidence of impaired quality of life, and there's some impairment of sexual function, and also that there is quite a bit of body shame and difficulty with intimacy in more than half of women, and evidence of depressive symptoms. So this is really data that suggests that both men and women with HH and KS may struggle with aspects of their sexuality and developing intimate relationships in terms of this psychosexual development. So what are some of the goals? So we talked, really this talk focuses more on psychosexual development, and we'll provide other talks which focus on different aspects of HH and KS. But really the goals for living with H are multifaceted. The first one is really about disease management. So we know that regulating hormone levels are really important for protecting one's bone health, developing the sexual organs, and with appropriate treatment, inducing fertility, as well as for stabilizing your metabolic health. So we know that men off treatment are very at high risk for having what we call the metabolic syndrome, which is a type of pre-diabetes. So there's other health risks when your hormone levels are low, predominantly to your metabolism and your bone health. The other aspects relate to health promotion, just like we would with any patient. So this means promoting and encouraging appropriate physical activity, encouraging a healthy, balanced diet and nutrition, as well as focusing on weight management and avoiding obesity, because we know that contributes to a number of negative health outcomes. We also want to focus on well-being, and this includes things like assessing sexual function. Are people satisfied with their sex lives? What are the aspects that are concerning them, and are there treatments or therapies that are available to help them with those issues? As well as addressing fertility concerns. Do people desire to have a family in the future? Those decisions need to be planned for in advance, because it can take some time. While 80% of individuals can develop fertility potential, it can take 12 to 18 months in men and a little bit shorter in women to induce fertility. And certainly, what are their concerns around intimate relationships? How can we help support them in developing healthy intimate relationships? And lastly, this idea of therapeutic education. So what is therapeutic education? Well, this is really about coaching and encouraging healthy lifestyle, and really trying to help people be their best selves. So this involves coaching for behavior change, if you think about both well-being and health promotion, as well as monitoring adherence to treatment, because we know when people have gaps in treatment, their hormone levels fall, and they have not only health problems such as decreased bone mass and metabolic complications, but those decreased hormone levels contribute to lots of other things like fatigue and low blood count like anemia, and difficulty concentrating and hot flashes and other things which can really impede people's health-related quality of life. So this is the point where we open up for questions. And based on this work, again, today was really focused on psychosexual aspects, but there's this fits into a larger body of work, which is done in collaboration with my colleague Richard Quinton in Newcastle in the United Kingdom, as well as with Neil Smith, who is a leader of the patient organization. So this is really a roadmap of how we think about how we can improve care and outcomes for patients living with HH and KS. So the first one, as we showed, this issue of identifying early, so moving that diagnosis early. Shortening that diagnostic odyssey for patients, because we know that the later folks are diagnosed, they tend to have poorer coping responses. So it's really important to improve detection, get people referred to specialist care in a timely manner, and move that diagnosis earlier to really facilitate a better coping response and better well-being outcomes. The second is really to empower patients to understand what they need to do to take care of their health. And this refers to the idea of self-management. Because frankly, for most people who live with a chronic condition such as a rare disease like HH or KS, more than 95% of the care that they ever receive in their lifetime is done by themselves. So they decide whether to take their medication or not, whether to go see a medical provider or not, to refill their prescription or not, and they're the first ones to notice when there's a change in their health status. So it's really important to inform and empower people to be able to effectively manage their condition. And also empower people to understand the importance of adhering to treatment long-term to minimize those risks for the negative outcomes, such as the impaired, symptoms of difficulty concentrating, fatigue, etc., lethargy, but also the bone health and the metabolic health. Lastly, we know that folks who are diagnosed in their teen years often are lost to follow-up in adult care. So these folks have gaps in care. So we really need to focus on how can we seal these gaps to keep the adherence to treatment and be sure that we're supporting people during this really critical time of late adolescence and early adulthood. So the goal here is to have continuity of care and a structured transition to help move people from a pediatric care setting to adult-oriented care, and to help coordinate their care, particularly if they have additional specialists involved in their care depending on their particular health needs. We also heard the call from patients very loudly about the need for support. So this is about providing language in lay language information, so not in scientific speak, but really in language that most people can understand. Also, the importance of peer-to-peer support. So that's really critical because, we've talked about this sense of isolation, and peer-to-peer support is a way to pierce the veil of isolation that many of these patients feel, and to help them recognize that there are other folks out there who understand what they're going through. And it's also a really important resource for crowdsourcing or drawing on the experiences and successes of others to figure out what are successful strategies that people have used. We also want to be sure to make appropriate referrals for counseling and therapeutic support for individuals as needed. And lastly, because patients are geographically dispersed, meaning that these are rare diseases, so it's not likely that your neighbor has the same rare condition as you. So people are dispersed all over the world, and so we really need to leverage and use web-based platforms to help people connect and find information and specialists about who really have a deep knowledge of HH and KS. And here's where it's not just about finding access to expert clinicians, but also to use patient expertise to help people find resources and support in a community to help them live and cope with effectively their condition. I do want to touch on some of the ongoing work that's going on. As I mentioned at the onset of the talk, I'm a member of the MGH Harvard Center for Reproductive Medicine, which is a funded research project through the National Institutes of Health, and it involves 3 centers: the Massachusetts General Hospital in Boston, Boston Children's Hospital, and Boston College. And my work in this large project is we're going to be holding quarterly patient meetings, which are virtual, to enable people to connect around the world. And we're also working on developing a patient-oriented website, and this is using a process we call design thinking. So developing the website with the end user in mind, meaning you all. And this is going to provide people with lay language information to learn about HH and KS. It'll provide links for people to find other patients and peer-to-peer support. It will also provide an opportunity for us to share with the patient community some of the discoveries that we're making in the center. And this will be released in lay language, simple language summaries to explain the work and from a scientific publication, but distilled down in a way that's pretty easy to understand for folks to understand what was done, what did we learn, and how might this change the care and counseling and outcomes for patients with HH and KS. And lastly, we'll be developing patient profiles. And this is really an opportunity to highlight the amazing things that many patients do, and that we really want to send the message that while this is a chronic condition, it's a lifelong genetic disorder, but it doesn't have to define one. So while you may live with a Kallmann syndrome, it doesn't have to define you as an individual. And part of this work is partnering with patients. So one of the aims is to have ongoing engagement with the patient groups, and that's what we're doing in the quarterly patient meetings. We're also developing concise, evidence-based guidelines so some of the work that we do is on gene discovery to understand the genes that underlie HH and KS. And we're developing guidelines to help clinicians return and talk to patients and families about these genetic test results. So really this involves understanding attitudes, values, and beliefs of patients, and then structuring the way that we can return results that are aligned with people's knowledge, their values, and their beliefs to really help them make sense of the findings and understand how those findings might be important for them, their family, and for their health decisions. And lastly, as I mentioned, to curate and co-create in partnership with patients the patient-facing materials, so educational materials, and a user-friendly website to really provide a trusted resource that is providing accurate and up-to-date information to help people gain knowledge and empower them to understand what they can do to best take care of their health and best live and achieve their full potential in living with HH and KS. That's our hope. So on the website, we will have patient-facing information such as understanding HH and KS. We'll provide summaries of publications in lay language. We'll provide patient narratives, which are diverse and represent a wide range of people living with HH and KS. And we'll identify role models, which is really important because sometimes when you're struggling with something, the best thing is to see somebody who is like you, who has been able to overcome this, and that can really be important for helping you believe that you can do it too. And it really is intended to have a positive focus, as I said, that an individual is not defined by their diagnosis, but is rather defined by the content of their character. We will be developing podcasts, which will respond to specific questions and topics identified from patients, and they may be including special interests such as aging, how older patients are living with HH and KS, questions around maintaining your bone health, perhaps intimate relationships or fertility. And lastly, we'll be creating a natural history study, which will be an opportunity for patients to share their information and help us better understand what we call the natural history. So how does this condition change over time? Because for many rare diseases, we don't really understand that very well. And we can only do that with collaboration and in partnership with patients. And that will be a shared resource that will be done in collaboration with the patient organization. And making sure that the questions that we are investigating are responsive to the things that are most important to the patient community. So really, this is a partnership and a co-creation process. So I thank you for your attention. I put my email here, and I'm happy to respond to questions or concerns. You can feel free to reach out to me. This will be one video in a series of recapping the content that we cover in some of our patient meetings for those of you who may not be able to attend. So thank you so much for your attention and appreciate your time.